audible? Please message me. Am I audible?
Yes, sir.
I'll change the slide and you just message me whether the slides are changing or not. Okay? Slides are changing. Okay, the slides are changing here. I'll just scroll the slide. You just tell me the slides are changing or not. You minimize it. फोटो देखिन्छ ना no. Okay, slides are changing. Slides are changing or not? You just tell me. Okay, slides are changing.
Yes, sir. Yes, sir.
Audible बंद कर देना. Disable annotation. Sound नहीं रह सकती है. Okay, now let's start the class again from the beginning. Okay. Okay, now I am Dr. Sanjeev Rijal. I'm an orthopedic surgeon in CMC. I'm an assistant professor. So I'll be taking your class on pediatric fracture shaft of humerus and pediatric both bone forearm fracture. Okay, whenever there is a fracture in the pediatric child, you should be very much cautious regarding the most important thing is the child is a growing bone. So there is a chance of remodeling capacity is very much common in children. So operative like intramedullary fixation or plates are not commonly used, but there are certain conditions where we have to use intramedullary fixation or a plating. Like you often see when you read books, you would see open reduction internal fixation with plating. These are less commonly done in children. They are mostly managed with the plaster and cast. So with this knowledge, I would like to start our class. So I have to cover 3 topics. They are very short topics and frequently asked questions in these topics. So let's start our class. Whenever there is a fracture of humerus, the child presents to your emergency with the pain, swelling, deformity, and unable to move his arm, and the child is coming to emergency with a crying, lot of pain. So when you examine the patient, you see some kind of a deformity. Then you take a history. What has happened? The patient, they will tell you that they have got some history of someone will tell you they have got a history of significant trauma. Someone fell from a bike or a vehicle, something that is significant trauma history, and some of them will give a history of a pathological fracture like an aneurysmal bone cyst, simple bone cyst, but the bone is weakened by a pathological causes and they sustain a tribal trauma, some slight strike in the forearm, then they will get a fracture. So whenever there is a history is not significant of a major trauma, then you should always suspect of pathological fracture. And another case is a child abuse. These are very much common, and especially you should be very much cautious regarding history. Child abuse, if there is a child abuse, you should examine the patient thoroughly regarding the bruises in the other part of the body. These are not so uncommon. The child abuse is also very common, so you should be very much vigilant in your history. So I have a picture next showing you the fracture of the humerus with a different stage of modeling. There is a fracture of humerus. There is a fracture of humerus, and these are, you can see a robust callus formation in day 7. Generally, in the fracture, the callus formation is seen in day 3 weeks. This sort of callus formation is seen in 3 weeks. But in the case of a children, there is a robust callus formation in day 7 itself. So whenever there is a callus formation, the bone gets sticky, and you can mobilize the humerus as early as compared to the adult. Now, I've already talked this. You have to take a thorough history examination and examination. In the case of a fracture humerus, you should never forget to examine the neurovascular status. Fracture humerus with neurovascular status. You should examine the pulses, brachial artery, radial artery, and the most important knob is a radial knob. And I think you know how to examine the radial knob. You should see that this is a wrist drop. You get a wrist drop in the case of a fracture humerus. You ask the patient to raise the wrist. The patient is not able to raise the wrist. Then there is a case of you should suspect of the radial knob examination. Radial knob is injured. So now when you have taken the history, you have done the examination, you have done the x-rays, you see the epilateral view with the both joint above one joint below, then you confirm it is a fracture humerus. Then now the question comes, how do you manage it? The management already I have told it, there are non-operative treatment as well as the operative treatment. Operative treatment are very less frequently done in case of children, pediatrics cases. So non-operative treatment, what can we do? There are a lot of options available. Like we can put a cast. We can put a cast, as well as we can put some sling and swathe cuff. Some splint SARMIENTO brace are there. And ROM, range of motion, has to be started as early as possible. If anyone has confusion, you can just chat. You can just chat me in. Now the non-operative, this is, I have shown some pictures. This is a hanging arm cast. Okay, this is hanging arm cast, and this is a sling and swathe bandage, and this is a SARMIENTO brace. And this is some of the acceptable criteria. When to accept it. So up to 2 centimeter of shortening is acceptable. Up to 2 centimeter of shortening is acceptable. And 15 degree of rotational alignment is acceptable. 20 degree of varus angulation is acceptable. For very much young children, up to 45 degree of angulation is acceptable. Are you getting me? I'll show you some picture. In this, as in the previous picture I have shown you. This, look at this. Look at this. If you see this shortening in day 4 X-ray, if you see there is some degree of shortening, but this degree of shortening is acceptable. Okay, and there is also some degree of angulation. If you see in this day 1 X-ray, you see some degree of angulation. This is not as straight as possible. So if you draw this line from here, and if you draw a line from here, and you see that we measure the angulation, if up to 45 degree of angulation is acceptable in the children. Why this much degree of angulation is acceptable, but we cannot accept this much of angulation in case of a adult population. We can accept only 10 degree of angulation. But in case of pediatric bone, there is a bone is growing, regrowing, remodeling potential is very much high in case of a children. So this much degree of shortening and these are acceptable in case of children. So and what are the operative indications? Now when do you operate? Whenever there is open fracture, the fracture is open, you have to do debridement. Then you think of fixing it something with some K-wire or some intermediate fixation. And whenever the angulation is, suppose a 13-year-old child comes and he has the angulation of 50 to 45 degrees, and that is not acceptable. You do a closed reduction, you cannot accept it. Then you have to do a intermediate fixation. And whenever there is a multiple injured patient, when you have to mobilize early, then operative fixation is advisable. And another case is a floating elbow. The meaning of the floating elbow is whenever there is a fracture of humerus as well as the fracture of both bone forearm. Are you understanding me? There is a fracture of humerus as well as the both bone forearm. Then this elbow is floating like this in the ear, floating. Then you have to fix the humerus as well as the both bone forearm. You cannot treat it conservatively. So these are some of the indications we have to, where we have to operate the fracture humerus. Now we are to, now let's this much of the humerus fracture. Now for the case of the forearm fracture, you have to study about the MONTEGGIA fracture, GREENSTICK fracture, and radius and ulnar fracture. So similarly, in case of radius and both forearm, also the cause is similar. The patient presents the pain, swelling, deformity. If there is a fracture is open or closed, you have to ask the history properly, and you have to examine the radial pulse, radial artery. You have to examine the radial artery examination, medial knob examination, ulnar knob examination, and posterior interosseous knob examination. In case of a forearm, the radial knob ends in the arm itself. Above the elbow, the radial arm ends, and below it, it continues as a posterior interosseous knob. So you have to examine the posterior interosseous knob. How do you say it is a posterior? In case of the medial knob, you have to see the OK sign is there or not. In case of ulnar knob, you have to see all the intrinsic function of the hands. And in case of a radial knob, you should see examine the this. In case of a radial knob, you will get a wrist drop. In case of a posterior interosseous knob, you will get a, because the patient can be able to extend the wrist, but he cannot extend the MCP joint. He can do this, but he cannot extend the MCP joint. You have to examine that in case of a posterior interosseous knob. Now the causes already I have told you: fall in the outstretched hand, direct blow, trauma, automobile accident, child abuse has to be taken in the forearm also. And there are some important terms has to be studied. Like isolated ulnar fracture, it's called the nightstick fracture. And the frequently asked question: what is Monteggia fracture? What is Gallagher fracture? In a Monteggia fracture, there is a M stands for the middle side. M stands for middle side. Middle side is a ulnar bone. So it is a fracture of ulna with the dislocation of the radial head is a Monteggia fracture. In a case of a Gallagher fracture is a fracture of the radius with the distal radioulnar joint. This is a frequently asked question in your competitive exam as well. Monteggia fracture, Gallagher fracture has to be known. So some of the pediatric fracture type. What are the plastic deformity? What is GREENSTICK fracture? What is complete fracture? This applies to all the pediatric bone fracture, not only in the forearm fracture. We study about the fracture. This can be in the tibia fracture as well as the humerus fracture as well as the all the pediatric fracture, you should know this term. What is plastic deformity? What is GREENSTICK deformity? And complete fracture. This is not only for the humerus fracture. This applies for all the fracture. The plastic deformity means there is no break in the cortex. In GREENSTICK fracture, there is a break in the only one cortex, like a torus fracture, buccal fracture. In the case of the complete fracture, both the cortex are broken, and this is quite unstable. Now you see, this is a plastic deformity, is like a plastic. When you mold the plastic, you see a plastic deformity. There is no break in the cortex, and this is a plastic deformity. And how to correct it? Sometimes you might need to break the bone. You might need to break the bone here to correct it. So you might have to create a fracture to correct the plastic deformity. Sometimes the plastic deformity does not get corrected. Then you have to break the cortex and align the fracture as straight as possible. In an incomplete fracture, look at this. Incomplete, there is a break in the cortex in the one cortex, but the another cortex is quite intact. So this is a GREENSTICK fracture, and these are quite stable fracture. When you once you put a force in the opposite direction of the fracture, then it gets easily stable. It gets stabilized easily. Then you can put a cast. And when you see this fracture, this is both the cortex are broken. Both the cortex are broken. Then these are quite unstable fracture. Then sometimes it's very much difficult to manage with a cast. Then you have to apply some intermediary fixation like the nail or a plate. So already I have told you this history, signs, symptom like pain, swelling, deformity, examination of all the radial knob, pestilential knob, middle knob, ulnar knob has to be examined thoroughly and documented well in the file. And in case of a fracture forearm, you should be always worried that there is always chance of having the compartment syndrome. So you should always ask, so what is the sign of compartment syndrome? In a case of a compartment syndrome, the patient may have pain out of proportion to the fracture. If the patient, you have put a slab and the patient is, and the patient comes to at the emergency at night, suppose at 10 o'clock, and you see the fracture, you have seen, you send an X-ray, you see the forearm fracture, okay, and put a slab and something splinted and go home. And your resident or someone who is intern, your intern, are sitting at the ward and they say the patient is crying heavily the patient is having severe pain, then you should always think of a compartment syndrome in a forearm fracture. So you should be very much vigilant regarding the forearm fracture. So you should ask the patient to lay in bed, keep your finger moving to prevent the compartment syndrome. If there is a compartment syndrome, you should not do delay in attending the patient. So in the case of compartment syndrome, you know there are some 3 P's: pain out of proportion, paresthesia, tingling sensation. They are commonly seen in the compartment syndrome. And pain on passive stretch. These are very much 3 cardinal P signs: pain out of proportion, pain on passive stretch, and tingling sensation, paresthesia. These are 3 P's. These are cardinal symptoms of compartment syndrome. And similarly, in the case of a humerus fracture, also we should send an X-ray of the forearm AP lateral with both elbow and wrist. That rule of 2 has already been discussed. I think we have to send an X-ray of both the elbow and the wrist. So whenever there are other than these are similar, the treatment option are as similar to the humerus fracture. You can put a cast, splint, or intermediary fixation like the K-wire. You can put Ross pin. You can put Stillman. You can put, or you can do a plating. Now the thing is the power of remodeling. This is a very much important concept in the case of pediatric fracture. Why we can accept up to 45 degrees of angulation in case of a children, or in fact up to 20, 30 degree in the case of older children. Then the thing is the remodeling potential is very much high. So we have to think of this concept. The remodeling potential is high, so we can accept the angulation. The one thing that does not remodel is rotation. So you have to try to achieve the rotation as much as possible. This rotation means this is a humerus fracture. You cannot fix like this. If you fix like this, this is a rotation abnormality. The rotation abnormality does not correct. So you should, but you can accept like this, because there is angulation translation can be accepted, but you cannot fix the bone like this. You cannot accept this rotational alignment. So this is you can go through this slide. There is a year of remodeling. Growth is the most important factor. Position of the bone. The nearer to the physis, the better. Suppose if the fracture of the humerus gets, or the forearm gets near to the physis, means the growing in lies in the elbow or the wrist. So if the fracture is near the elbow, they are more chance of getting remodeled because they are closer to the physis. So whenever there are deforming force, in which position you should apply, because of the deforming muscle force, the level of the fracture determines the forearm rotation and immobilization. In the proximal third fracture, you should fix the forearm in the supination position. Supination, this is supination, this is a mid-prone, and this is a pronation. Whenever there is a fracture in the distal third of the forearm, you should apply a cast in the pronation. Whenever there is a fracture in the middle third, you should apply in the neutral. Whenever there is a proximal third, you should apply in the supination. So after post reduction and casting, you have applied the cast. You should always explain the patient about the complication of cast, like there is chance of compartment syndrome with the cast also. You should always warn the patient regarding the compartment syndrome after the application of the cast. If there is a patient, you should always counsel the patient if there is a excessive pain, excessive swelling, numbness in the hand. You should immediately report immediately, and you should, if there is any sign of compartment syndrome, you should remove the cast. So you should always explain the patient after application of the cast, the complication of cast. And you should take a serial check X-ray has to be done after 1 day, 2 days, after 1 week, 2 weeks. You should do a serial X-ray so to see whether the fracture has displaced or not in the cast. And now these are the similar operative indication in the case of a operative indications are there's called honest structural criteria, open fracture, floating elbow, segmental fracture, neurological fracture, and some surgical stabilization and coordinated fracture is required in only 31% of the cases. So what are the implants that can be used? Similar in the case of the humerus, then we can use the intramedullary nail or we can use a plate. So this is a look at this. This is a fracture and this has been fixed with the intramedullary fixation with the K-wires. Some of these are the acceptable criteria. I'm going to accept it. The acceptable criteria is 20 degree of angulation in distal third of shaft of fracture of radius and ulna, 15 degree at the mid shaft and 10 degree at the proximal third. You can accept it. Now this is the terms called the Gallese fracture. What is we already have discussed? What is Gallese? Gallese is a fracture of the distal radius as the dislocation of the distal radioulnar joint. Now is a Monteggiia fracture. Monteggiia fracture is a fracture of the ulna with the dislocation of the radial head. This Monteggiia and the Gallese fracture will be discussed in your other classes also. So I have just mentioned it. Just you try to remember that a Monteggiia is a fracture of the ulna with the dislocation of the radial head, and Gallese fracture is a fracture of the radius with the dislocation of the distal radioulnar joint. So this is a Bados classification. If anyone is interested, you can go through this slide. But for the MBBS level, it is not so much necessary. But this can be asked for MPS level. It's not necessary, but this can be asked in a competitive exam, like in a AIMS exam. If you are preparing, you are planning to give your exam for in AIMS or PGI. These questions are frequently asked. Type 1 Bados, type 2 Bados. So you have to, it's better to you get through these studies. Nothing, this is very much easy. There is a fracture of ulna with the dislocation of a radial head. This is a fracture of ulna with the dislocation of a radial head. This is anterior dislocation. This is a posterior dislocation. This is a lateral dislocation. In this type 4, there is both the fracture with the anterior dislocation. So Bados is not so much difficult. If you go through this slide, I'll show you. I'll just show you once. Look at this. This is an ulnar diaphyseal fracture with anterior dislocation. Ulnar diaphyseal fracture with anterior dislocation. If you see this, this is ulnar fracture with the dislocation of radial head. This is type 1. So if you see this, there is ulnar fracture with the radial head dislocating posteriorly. So this is a type 2. Look at this. Ulnar diaphyseal fracture with the posterior dislocation of radial head is type 2. And if you see this picture, there is a anterolateral dislocation. This is a lateral dislocation. So this is a type 3 fracture. Look at this. If you see this theory, there is a lateral dislocation of radial head with the ulnar metaphyseal fracture. In the type 4 Bados, if you see this type 4, these are both the fracture, both the bone are fracture. In this, only the ulna was fracture. But in this, both the bone are fracture and the radial head is dislocated anteriorly. So this is a type 4 Bados. So this is not so much difficult to memorize. Basically, you can memorize this picture, then we can get a concept. This is not so much difficult. But if you are preparing for a competitive exam, these are frequently asked questions. Otherwise, this is not so much, not frequently asked for the MBBS level. So this is all the thing. And this another concept is you should get an X-ray, AP, and the lateral of the forearm, and the radiograph of the joint of the forearm. As to if I'll show you this picture. Look at this picture. This is a humerus. This is humerus. This is ulna. If you see the radial head, if you draw a line from the radial head, this middle of the radial, it should cross the capitellum. In any position of the elbow, it should cross the capitellum. This position also it is crossing the capitellum. This position also is crossing the capitellum, and this position also is the capitellum. If it does not cross the capitellum, then you should suspect the radial head dislocation in X-rays. This is the importance. It's best if two lateral view, a line running the long axis of the radius should bisect the capitellum of the humerus, regardless of the degree of flexion extension of the elbow. So if it is not does not cross the radius, and if this line does not cross, then you should suspect the radiocapillary dislocation. I think this is the very much short presentation. So it is not a very difficult topic. You can go through the Maheshwari. It's a very much easy topic to study, but some of the important concept is, in case of a pediatric fracture, you should always think of a child abuse is one of the important take-home message. You should understand about you should examine the child properly, you should examine the knob examination, you should know the acceptable criteria, and you should know the some of the operative fixation, operative indication, and method of fixation. This is not so much difficult. So if you have any question, you can ask me, you can chat box, and I'll try to reply it. Any question? No questions? Hello? Anybody has any question? Okay, there are some questions I will try to explain. I'll try to explain some of the questions that I have been receiving. So, okay, some of you has suggested that I'm going too fast. Okay, sorry for that. I will try to improve my, I think, in the next presentation. So, floating elbow once again. So, Mr. Suman Kumar has asked me, what is floating elbow? So, the concept is very much simpler. Floating elbow means there is a fracture in the humerus and the forearm. Both same patient has a fracture in the humerus as well as the forearm. Then the elbow is like a floating in the air. That is floating elbow. Mr. Suman Kumar, did you get me? Please message me. Suman Kumar, did you understand this, the concept of floating elbow? Okay, so he got his answer, and I'll go slowly. I'll see the question. Floating elbow once again. Okay, so radio-capital relation. So it's a. I'll show you this X-ray. Whether this marker is visible or not. Hello. Okay, just you message me whether some drawing is visible or not here. Okay, not this one. Okay, if you draw this line, whether this marker is visible, this cursor is visible or not. This cursor is visible. Mouse is this cursor is visible or not?
Yes, sir.
Okay, if you draw this line from this is the radius. Okay, this is both are radius. If you draw this line, see, imagine this Ky as a line one. If you draw this line, it should go to the capitulum. Okay, it should go through the capitulum. If this line does not cross the capitulum, then you should suspect of radial head dislocation. And this should be in any position of elbow. If you see this, I'm drawing a line from the radius. It is going through the capitulum. And in this position of elbow, it is also going through the capitulum. If this position also, it is going through the capitulum. So this is a radiocapital relation. You should always see in the X-ray. I made you clear or not? I don't know. Who has asked me this question? Bipan Gurum. Did you understand this? Mr. Bipan Gurum, please message me. Okay, yes, got answered. And another question was something radial nerve damage. Boy, manage ko sari karne. Okay, Mr. Ashish Sapkat, if there is a radial nerve damage, if you have read your basic properly, the radial nerve damage, there are type of nerve injury. It could be neuropraxia, it could be axontemesis as well as the neurontemesis. Most of the cases, 90% of the cases of the humerus fracture are the radial nerve injury is of neuropraxia type. Neuropraxia means it will recover itself. 95% chance the radial nerve damage will recover itself. So it can be managed conservatively. We should wait for 3 weeks, 3 months to see whether the knob is recovering or not. If the knob is not recovering after 3 weeks in EMG study, then we should go and open and see the radial nerve. Otherwise, can be managed with a simple cast, and we can keep observation. We can do it, and it will recover. Most of the cases time it will recover. If it is not recovering, then we have to go and see the knob. We have to open. You have to do open. You have to open the fracture. You have to see the knob, and you have to, if there is injury, you have to repair it. Mr. Ashish Sapkota, did you get the answer? Please message me. I have to answer other question also. Mr. Ashish Sapkota. Okay. And another question where I have got some questions. Cast versus slab. Kasto condition में slab use गर्छ sir. Okay, the cast and slab are two different entity. The cast is means you apply a cast. This is suppose something this you apply is 360 degree. We have got POP. Have you seen POP? We have got POP. We apply this 360 degree. Whole like a circumference of 360 degree. That is cast. Cast is used for definitive management. Cast is used for definitive management. It can be used to hold the fracture. Cast and slab. Slab is a in the case of a slab you do not apply it 360 degree. Just you apply 180 degrees only covered in the case of a slab. Slab is not generally used for definitive purpose. It is used for some splintage purpose, and cast is used for the definitive management of the fracture. Who has asked this question? Mr. Samir Sharma, did you get your answer, please? If you have got your answer, please just message me. Okay. So rotational management again. So this rotational management is a bit difficult to understand without showing you something. Because just I'll try to something this. Look at this pen cover. You have seen the pen cover, something like this. Seen something like this? Am I? You are visible? You are seeing me or not? Who has asked me this regarding rotational alignment? Diksha. Diksha asked me something about rotational alignment. If you see this pen, this is both in are fracture. These are fracture. If these are hello, if you see this fracture, so this is angulation. This, if you draw this line, this is angulation. The fracture can be this two has to meet. If this much of angulation is acceptable, but this rotation, if you see this white part, it has to be here. You cannot fix the fracture like this, rotationally aligned. You can fix the fracture like this. There is no problem in fixing like this. The angulation is acceptable, but if you fix this like this, then this is not acceptable. This is rotationally malalignment, and this rotational alignment will not remodel. So you can do this one is also acceptable, but you cannot accept this. I mean, rotational alignment is not acceptable. So it's a bit difficult to explain in this, but I think I tried to explain this. I don't know if you got it or not. Diksha, did you get it? Okay, if you do not understand it, you can search in YouTube or something. They will tell you about rotational alignment also. Okay, I think I have explained. I think most of the things has been explained. I think. If you have any other question, please. I didn't see other question. If you have see another question, you please explain me. Okay, I think this is it. If any question is still I am online, you can ask the questions. Okay, then if there's no question, then I will disconnect it.